Hello and welcome back for another video discussion in this series about clinical toxicology. I'm Dr. Suchard, and this time we're talking about iron poisoning, corresponding to Chapter 45 in Goldfrank's Toxicologic Emergencies. The learning objectives today are that you'll be able to describe the expected signs, symptoms, and time course of acute iron poisoning, estimate the degree of iron toxicity based on the ingested dose, and be able to outline a diagnostic workup and treatment plan for a patient with acute iron toxicity. Iron poisoning used to be a much bigger concern than it is today. Up until the 1990s, iron had been the leading cause of medication poisoning deaths in children 6 years or younger. Part of the issue was that iron was so easily available and maybe not respected or feared enough. Iron is in over-the-counter supplements and multivitamins that are sweet and come in cartoon character shapes specifically to appeal to kids. And people taking prescription iron supplements are often found in homes with small children. Perhaps their siblings are being treated for anemia or their mothers. But a number of risk-mitigating factors were enacted, constituting a remarkably effective response and a relative victory over a toxicologic scourge. This is the system actually working. There were Poison Control Center educational efforts, new warning labels, and prescription iron supplements were required to be dispensed in blister packaging, making spontaneous overingestion much less likely to occur. Various iron supplements contain different percentages of elemental iron in them, depending on the other part of the iron salt that's in them. The most commonly encountered iron supplements out there are ferrous sulfate, which are 20% elemental iron. So if a person ingested a typical 325 milligram pill, that would be 65 milligrams of elemental iron. If the number of pills ingested is known or can be estimated, then you can calculate how many milligrams of elemental iron there were, and from that, what the ingested dose was in milligrams per kilogram. Significant toxicity is not expected with ingestions below 20 milligrams per kilogram, and if there's a call to a poison control center, with that degree of exposure, they're likely to try just monitoring the patient at home as long as they remain asymptomatic. That threshold of 20 milligrams per kilogram, though, needs to be taken with a grain of salt, because poison center calculations like this are always made rounding things off to create a worst-case scenario. The child might have ingested so many pills, because that's the number of pills missing from the bottle, but we're not sure they actually took that many, and their actual exposure might have been, and likely was, less. So it's quite possible patients may become symptomatic with ingestions less than 20 milligrams per kilogram elemental iron. Normally in the body, when iron is transported, it's always bound to some protein because free iron is toxic. Of course, with an iron overdose, it's possible to outstrip the body's ability to bind up that iron. The free iron levels increase, and this is what causes toxic effects. Ferrous, or +2 iron ions, convert to ferric, or +3 ions, and back again, generating hydroxyl radicals and other reactive oxygen species that cause all sorts of havoc, damaging proteins, lipids, and nucleic acids, inhibiting oxidative phosphorylation and other critical metabolism, resulting in cellular injury, metabolic acidosis, and an elevated serum lactate. Iron toxicity is commonly described as occurring in a series of 5 clinical stages. We're assuming here that a patient ingested too much iron, so it starts off in the GI tract. Stage 1 is from irritation directly to the gastrointestinal mucosa as the free iron is in contact with it. The patient will have abdominal pain, nausea, vomiting, possibly diarrhea, and possibly with some associated GI bleeding. This lasts for a few hours, and patients might symptomatically get better. Maybe they got better because it was a relatively small overdose and they'll recover fully. But maybe it's a larger ingestion, yet the patient only appears to get better as they enter stage 2. The GI symptoms resolve, but this is because the iron has already passed through the GI mucosa and is dispersing systemically instead. The symptoms might be better here, but the patient should be developing progressive laboratory abnormalities. And some patients with larger overdoses never have a latent stage but go directly to stage 3 with shock, worsening lactic acidosis, and then in stage 4 the liver takes a major hit. Should a patient survive serious iron toxicity, they may go on to develop scarring of the GI tract, which can lead to bowel obstruction. The workup for a patient with iron poisoning can include X-rays. Since iron is a metal and metals are radiopaque, you may be able to see iron pills in the GI tract. Blood test markers of iron toxicity include an anion gap metabolic acidosis and an elevated lactate. Other indirect markers of toxicity include elevations in the white blood cell count and the serum glucose. These are probably just markers of the physiologic stress, and these associations were noted in a time when rapid serum iron levels were unavailable, so all we had were indirect markers of iron toxicity. We'd also like to get serum iron levels if they're available, which is a more direct measurement. Theoretically, you wouldn't see iron toxicity if the iron level remained below the TIBC, the total iron binding capacity, because there would be no free iron yet. However, it is possible to see iron toxicity when the iron level and the TIBC are fairly close, because the TIBC can become falsely elevated in these conditions. For the most part, as with many poisonings, treatment of patients with iron toxicity is symptomatic and supportive. With regard to GI decontamination, there are a few issues. First, most iron poisoning patients will already have emptied their stomachs due to vomiting. You might consider orogastric lavage, especially if you see iron pills in the stomach on X-ray, but the pills may be too large to pass through the tube, and the pills might form an adherent mass or concretion. If there is a known or suspected mass of iron pills, whole bowel irrigation should be considered. There is a specific treatment, an antidote for acute iron toxicity, deferoxamine. Deferoxamine chelates iron, binding it up and reducing the amount of free iron. Interestingly, if you calculate how much iron gets bound up to the deferoxamine at the doses used, it's only a very small amount, which wouldn't seem to be enough, but it still definitely seems to help. If a patient with an iron overdose starts to develop significant toxic effects, as listed here, they're candidates for deferoxamine therapy, which we're going to discuss more in a separate video. And here's the recommended decision analysis algorithm from Goldfrank's textbook. Feel free to pause the video or to check the textbook, because I'm not going to belabor the point to read through this whole thing. That would be boring and unnecessary. So that's it for my discussion of iron toxicity. I'll be seeing you around.